my dear friends. Pranam. Thanks to the scientific committee for giving me this opportunity to present an interesting case of respiratory distress, which was really challenging to me and more challenging to present within 7 minutes. A dear female child was brought to my OPD with complaints of difficulty breathing for 4 days, rapid rate of breathing, with chest involved for 2 days, already taking treatment with no relief, history of repeated episodes of difficulty in breathing since infancy, and getting some relief from some nebulized medications but never hospitalized, and family history of atopy was positive. So on clinical examination there was tachypnea, severe chest retraction, rectus excavatum was evident, body temperature was normal, there was hypoxia, chest monoscultation, they sound barely audible all over the chest with harsh sound over the upper left intercostal region, and no adventitious sounds in the form of pseudotrachals, and on anthropometry there was faltering growth. So sometimes management persists, investigation and diagnosis. So I admitted the child and put on oxygen and IV fluids, nebulized with salbutamol 3 times, no response, then added ipratropium, 3 times nebulizations, no response. Then given IV hydrocortisone, and after 4 hours seeing no response, I have given magnesium sulfate infusion with very little response. In view of no response, chest X-ray was done, which was normal. Then I planned HRCT chest to look for what is this. So what was my thinking pattern at that time? So I kept first possibility of uncontrolled asthma with acute severe exacerbation in view of history of frequent nebulization with response and family history of atopy. Other possibilities I kept that in view of no response to other medications after 24 hours, I thought it may be some inborn error of immunity or acquired error of immunity due to faulting growth and frequent use of antibiotics. I thought it may be ILD due to infantile projection of surfactant protein C mutation leading to absent or decreased surfactant protein C, because child projection was meeting the criteria of childhood interstitial lung disease, and this disease, entity particularly SFC, is notoriously known to be associated with severe RSV infection and its consequence in infants and children. And then lastly, I thought it may be due to ILD with some environmental exposure. So first report came of HRCT, there was bilateral diffuse ground glass opacities, and it was written that there is possibility of alveolar proteinosis. So in view of suspected ILD and no response to asthma medications, I gave pulse methylprednisolone. So first dose gave detectable response. After the second dose, there was marked improvement, and after the third dose, there was no chest retraction. Respiratory rate became normal, and the child was comfortable breathing at room air, and there was no hypoxia. So further investigations came. I then interpreted the reports. CBC, LFT, KFT, non-contributory, but on immunoglobulin profile, IgG was raised, and serum total Ig was markedly raised. And anti-GSM CSF antibody could not be done due to unavailability, and serum specific IgE and IgG against Aspergillus fumigatus was raised. So I kept the possibility of asthma uncontrolled with ABPA with severe acute exacerbation. The patient was discharged with some inhaler medications, and I prescribed itraconazole or steroids and advised to review at clinic. The child was stable at follow-up with good air entry bilaterally, but sometimes we end up diagnosing as comorbid conditions leaving behind the devastating disease. So I kept on thinking and searching what it is. At follow-up, spirometry showed restrictive pattern. Now I wanted to rule out ILD and planned bronchoscopy, but parents were hesitant for that. There was no history exploration. There was no factory nearby the house, but many visitors were coming daily in their balcony in the form of pigeons. So I went for serum IgG for pigeon droppings and feathers. So report came, serum IgG for pigeons droppings and feather was positive. Now the diagnosis was bird fancious lung disease, a variant of hypersensitivity pneumonitis. So this was the diagnosis at this time, and treatment was modified. I gave oral prednisolone, inhaled medications was stopped, and advised allergen avoidance, and then repeat chest X-ray after 6 normal serum parameters, child was growing well. So these are the two HRCT at presentation, and after 6 months it is going normal. So on reviewing the literature, it is a heterogeneous childhood intestinal disease, hypersensitivity pneumonitis, usually unrecognized considering a disease of adulthood. Pathologically, there is interaction of environmental antigens to host immune system in genetically predisposed individuals in an aberrant way. In children, the antigen is usually in home environment like avians, fungus, aspergillus, also inhalation of paints, plastic, second-hand smokes. After repeated exposure, the immune complex gets deposited and destroyed in the interstitium, internal and respective bronchioles, and level of IgG against the antigens gets elevated in the serum as it is IgG mediated immune reactions, and there is activation of Th2 type leading to high level of CD4 plus cells. So clinical presentation depends on type, intensity and duration of exposure of antigens in susceptible host with dysregulated immune system. It is classified into two, but this classification is not easily separable. It is a spectrum of the same disease, and clinical features are mainly dry cough, dyspnea, weight loss, hypoxia, velcro-placal zone auscultation, and less oftenly there may be wheezes. Acute exacerbation has been defined as acute depression with respiratory symptoms and signs in previously stable patients needing change in routine management. So, early diagnosis is mandatory to save the child. Diagnosis depends on history suggestive of environmental exposure, respiratory symptoms and signs meeting the criteria of childhood interstitial lung disease syndrome, and diffuse bilateral obesity of HRCT chest. Laboratory test shows peripheral eosinophilia, major may be peripheral eosinophilia, and raised serum IgG against the suspected antigen, and PFT findings shows restrictive disease pattern. If these are there, it further augments the diagnosis. Only in uncertain cases, bronchoscopy and pulse field examination is required, and only rarely lung biopsy is needed. So there is a paradigm shift in the diagnosis of ILD in children from lung biopsy to history, HRCT chest and genetic examination. So the treatment is mainly antigen avoidance, but even after keeping away birds, the antigen may persist in home environment for a long time. So oral prednisolone is given. Duration depends on the type of the disease, acute or chronic. Intravenous steroids for persistent symptoms and persistent HRCT finding with severe impairment in lung function. Pulse methylprednisolone is given for acute severe exacerbation. Hydroxychloroquine and azithromycin in combination with intravenous steroid should be given in ventilator patient or patients close to ventilation. But there is no evidence-based types of ILD in children to treat these conditions, and experiment is going on for rituximab. Inhaled corticosteroids may have a role, but it needs further trials to recommend this. So these are the references, and thank you very much for listening. I think I have finished my time.